Good afternoon, everybody. My name's Megan Nolan, and on behalf of the Adelphi Society for Psychoanalysis and Psychotherapy, also known as ASPP, we'd like to welcome you to our first presentation of our 2024 Meet the Author series. The workshop is for an hour and a half. The presentation and the interview will be about an hour, and then we'll open it up for discussion. Today's event is non-HIPAA compliant and is going to be recorded and posted on our ASPP website. Please keep in mind that not everyone in our audience today is necessarily a clinician. If you bring up any case material during our discussion, please keep it brief, relevant, and extremely de-identified. For CE credits, the evaluation link will be emailed to you right after the workshop to all those who've met the 90-minute New York State time requirement. Please fill it out and return it to us by February 2nd, this Friday. Thank you. Before I introduce Dustin Cahood, the chair of the ASPP Meet the Author Committee, I'd like to thank our director of the postgraduate programs, Amira Simha Alpern, for joining us tonight and for always supporting the work we do here at ASPP. And lastly, if you're not a member, an ASPP member, please consider joining our community. The 2024 membership enrollment is currently open, and we'll send you a flyer, as well as we're going to put the link to the enrollment in our chat today. Okay, thanks again, everybody. Dustin?
Welcome, everybody, to today's Meet the Author event. We are delighted to have co-authors Drs. Danielle Knafo and Michael Selzer to discuss their recently published book, From Breakdown to Breakthrough, Psychoanalytic Treatment of Psychosis. Danielle Knafo is a clinical psychologist and psychoanalyst with expertise in the treatment of psychosis. During her tenure as professor at LIU's clinical psychology doctoral program for 22 years, she chaired a concentration that trained doctoral students on how to work therapeutically and psychodynamically with serious mental illness. She received the Barbara Sandin Prize for this work. Currently, she is faculty and supervisor at Adelphi's postgraduate programs and NYU's postdoctoral program in psychoanalysis. She's written and lectured extensively on the topics of art and creativity, psychoanalysis, trauma and psychosis, gender and sexuality, and most recently, technology and AI. From Breakdown to Breakthrough, Psychoanalytic Treatment of Psychosis is her 10th book. Dr. Knafo has worked psychodynamically with psychosis for over 40 years, and she maintains a private practice in Manhattan and Great Neck, New York. On a personal note, Danielle Knafo is now a mentor, colleague, and dear friend, and was originally my professor and dissertation chair, and later co-author of a book that we presented for the first Meet the Author in 2019. Danielle was the first person who got me into psychoanalysis, both literally and figuratively speaking. She has inspired me and so many students to pursue psychoanalytic training over the years, and has helped so many students to really seek out the passion that first drew them to psychoanalysis in the first place, the pursuit of the unconscious. She's a major figure in the field who's keeping psychoanalysis alive in talks at Adelphi, also around the world, and continues to do so, as you will see here today. Danielle and Michael have co-authored a number of papers prior to their book, this book that we're discussing today. Dr. Michael Selzer is a psychiatrist whose major career focus has been the training and treatment of psychosis and borderline personality disorders. He worked at Cornell University Medical School, Payne Whitney Clinic at New York Hospital, Westchester Division, where he directed the Schizophrenia Division, a long-term facility for treatment of persons with refractory chronic schizophrenia, and a major site for training post-residency and postdoctoral fellows in the treatment of chronic schizophrenia. He has received many teaching awards. He is the co-author of 4 books prior to this one, including Working with a Person with Schizophrenia with Monica Karski, and has written many papers on schizophrenia, a number with Dr. Knafo. He's worked psychodynamically with psychotic patients for over 60 years. He maintains a private practice in New York City. So let's begin. Danielle, other than what I learned from your class in psychosis, my cohort and I received very little exposure to learning about working with psychosis in grad school, and yet so many therapists do work with psychosis in hospitals with very little knowledge. It seems this is common amongst grad students and graduate programs in training to become therapists. Your book was full of information about the psychoanalytic treatment of psychosis and the many conceptualizations and approaches. The cases in the book illustrate different manifestations of psychosis and different ways of treating these different forms at different stages, from the onset of treatment all the way to termination. The book had me thinking about my own cases in a way I had not considered before. It had me thinking a lot about the ways in which psychosis sits at the core of the human mind in a universal sense, and how psychosis is like seeing the unconscious exposed in its raw form. That made me think about the potential for breakdown in anyone. So can you tell me about this title, From Breakdown to Breakthrough?
Sure. So the title went through a few iterations. At first, it was Unraveling Psychosis. I thought, psychosis unravels and we unravel the meaning. Then it was Coming Undone. But we wanted something a little more positive because the book is about treatment of psychosis. And we believe that people who experience psychotic episodes are treatable. And so I thought of something that one of my patients had said in the midst of a psychotic episode, and he's in the book, it's chapter 10. He questioned, am I having a breakdown or a breakthrough? And we both came to the conclusion eventually that the breakdown led to a breakthrough. And so I thought that was a wonderful way to describe what our book is about, from breakdown to breakthrough, because it has a positive, direction. And
Right.
we do believe, Michael and I, that psychosis is treatable, and particularly by psychoanalytic means. As far as psychosis being universal or potential in all of us, as far as your question about the universality of psychosis, I think, a lot of psychoanalytic writers believe that psychosis is universal in all of us. Michael Eigen wrote about the psychotic core. He actually pointed out to me that Bion wrote a paper in 1975 called Break Up, Breakdown, Breakthrough. But he only pointed that out after the book came out. So it was interesting, similar thinking. But Eigen wrote about the psychotic core in all of us. Bion wrote about the psychotic and non-psychotic parts of everyone's personality. Freud said that we are all psychotic at some times, especially when we dream. Jung said a great psychologist is someone who must spend his life in a hospital, in a mental hospital. The question is whether as a doctor or a patient. So the idea that psychosis has a universality is not foreign to us. And even though a lot of people try to distinguish between the so-called normal, neurotic, psychotic, as if psychosis is a different entity. And we'll get into that more, I think, about, how psychosis is regarded as a biological disorder as opposed to neurosis and personality disorders, let's say.
That's why you decided to start writing this book together at this point. What were the reasons? Were those the reasons that you decided to write?
We had many reasons. Mike, why don't you say a few of the reasons that we had for writing this book?
My main reason for writing this book, and my hope is that some of this will come through, or if not, the audience will tell me why it isn't, is that 50 years of training people to work with psychotics has convinced me that there is an enormous bias, as reflected, for example, in training programs, analytic training programs, toward even approaching this. And what we felt was vital, and even that we could provide, would be a template, a format, a way of looking at the interaction such that people would have a guidepost with the danger, as I think both of us recognized, I certainly did, the danger that the rigidity of leaning on a guidepost might eliminate the spontaneity that's absolutely essential. So if successful, people who held their nose before about approaching psychotic individuals, precisely because they were either afraid or felt, understandably, ill-equipped by virtue of educational deficiency, actually, would now have a sense that it's possible. It is possible. And also, I hope that the way the chapters were written would give people an opportunity to feel free to put their own idiosyncratic take on everything we wrote, because the essential ingredient in working with psychotic patients, as well as working with neurotic patients for that matter, would be being real. And you can't be real if you're borrowing someone else's methodology.
Right. So why do you think so many people tend not to work with psychosis in psychoanalytic practice? It's for either of you. Yeah.
Because people, if their education stops at the door of psychosis, then the message of the authority figures that's being given to the potential therapists is, stay away from this. We have nothing to offer. If you look at a pedagogy and see that it ends with borderline patients, however shakingly ends with borderline patients, then you get a message from the people you're relying on, stay away. That's one thing. And the other thing that is emphasized again and again in the book, and is certainly my experience from all these decades of supervision, is that the fear of recognizing, of revealing to oneself, if only confronted by the patient as the source of that revelation, is very strong, much stronger than I had anticipated originally. Maybe that's because I grew up in a Meshuggah family, but at least I was familiar with the unpredictability of life, and particularly for beginning people, stability is what they need to offset their anxiety about being neophytes.
I can add to that. I think I agree that our training, most of our young clinicians' training ends at the door of psychosis, as Michael says. But also, we have, in this country at least, handed over the treatment of psychosis to psychiatry and psychopharmacology, as if we have nothing to offer. And that is really unfortunate. And as a result of that, both clinical psychology programs and psychiatry educational programs have decided that therapy is not something we have to teach to our early clinicians. And what happens is that these clinicians, when they do encounter psychosis, which they inevitably do, because if you're working with people, not everyone presents with psychosis, but people can have psychotic episodes in the course of a treatment. These people are completely ill-equipped and unprepared to work with these cases. And so it's very few programs that have courses and training in the treatment of psychosis. And that is why we wanted to write this book, to provide a guide for people who are interested in working with psychosis and learning how to do it. And the book begins with the very first initial encounters all the way to, you know, termination and supervision, because both of us have taught and supervised a lot for these cases.
Right,
I'd
right.
add one more thing from a medical perspective. That's an inherent resistance. When I was in medical school, there was a great deal of embarrassment about many of my colleagues who thought they might become interested in psychiatry. That the reason that psychiatry was looked down upon was that it was not scientific. And that urge to belong among medical students and doctors in general, if you were a psychiatrist, required you to acknowledge, accept some bona fides in the scientific world. And along came medicine. And now the psychiatrist could say, I am being a real doctor. My interventions are easily quantifiable, and I belong with you. And that's been an important variable.
Yeah.
Right, right. So how do you work with symptoms of psychosis from a psychoanalytic perspective, whether outpatient, inpatient? How do you work with those symptoms therapeutically?
Well, mostly we work with symptoms, unlike, you know, psychiatry or CBT. And CBT has begun teaching a lot on how to work with psychosis, more than psychoanalysis, by the way. But unlike those two approaches that try to eliminate symptoms, we see symptoms as an entry point to understanding the patient, to working with the patient. We don't immediately rush to eliminate a symptom, because the symptom carries the meaning and the you know, the heuristic value of what the patient is going through and what is important to the patient. So we give a lot of importance to this symptom as an entry point, as an looking in, as a sign that a human being is actually struggling for their life, how to create an alliance by working with a patient's symptom. We give, you know, a lot of guidelines about how to work with symptoms, positive and negative. Most people, when they think about working with symptoms, they think about positive symptoms, hallucinations, delusions. This is what they see. This is why a lot of people are hospitalized. But many people who suffer with psychosis suffer with negative symptoms, the symptoms that represent lack or absence, or you know, a lack of motivation, lack of pleasure, lack of connection, isolation, lack of you know, body movement, of eye contact. And so they're often, they don't come with these, you know, significant, more flamboyant symptoms. It's more a general way of presenting that many see as unreachable and a kind of deadened. And so they are often the patients who suffer with psychosis who are deemed chronic and unredeemable, unfortunately. But we have chapters on working with positive symptoms and on working with negative symptoms, because it's not the same. It's not the same kind of work. People with negative symptoms, you can't just, you know, you're not as active in a way. You do much more holding and witnessing and containing until the person feels safe and is ready to slowly emerge from their retreat.
Right.
Mike, you wanna add?
Yeah, I want to add a couple of things here. What Danielle is talking about, which I absolutely agree with, is the centrality of symptoms, is that to deal with that means in a way to linger with those symptoms. And the more you linger with those symptoms and present an attitude of regard rather than dismissal, the more you run the risk of reminiscing in a way that brings you back to yourself. Now, what do I do with this similarity? How do I protect myself? Could I become like this patient across the way? So, being the authority figure, as many treatment models are, provide you with safety, with security, with an identity that is almost unassailable. Whereas the more you linger with symptoms together, the greater the possibility of recognizing, I've been there too. There's something about this, there's something about this that's familiar to me. What do I do now? And it's at that point that I find, anticipating some other questions, that supervision is most critical.
Yeah.
What do I do now? I don't want to become him. And
Yeah.
part of what I've learned is admiration. After a while, I don't want to become him leads to, who is he? Leads to admiration and respect for what he is trying to do, not necessarily for being entirely effective, but for trying not to lose his existence. And paradoxically, in that effort, thwarting the efforts of many therapists. But he is struggling for his life. And to the extent that I recognized, and the patients make me recognize, how often I've struggled for my life, there's something shared about that as I'm re-experiencing it right now. There's something shared about that that creates the opposite of difference, and that is crucial. And the initial reaction of the patient to that opposite of difference is not embracing. It's more fear, more withdrawal, more likelihood to look like, you've hit the wrong note. So what you have to trust at that point to know that you haven't hit the wrong note is your own authenticity. He reached me in a way that I've chosen not to be accessible to. He reached me. That's crucial.
Mm-hmm. So,
And to add to that, that's what Mike said about this point being very critical for supervision, because at that point, many therapists become very frightened about what they're facing, not just in the patient, but in themselves. And to go back to your first question, Dustin, why don't a lot of people work with psychosis? That's why. They're afraid of the closeness, because we're so used to putting them into this other category of an other, that when it comes close, people get frightened too. Bertram Karen said the only consistent thing that he found in working with psychosis was fear, an intense fear in the person who experiences psychosis. But those who work with psychosis also feel and experience that fear. And that can deter many people from doing this work. And yet, if one can overcome with supervision, hopefully, the fear of contagion, of, what are we facing within ourselves, then there's a lot of reward in this kind of work. Harold Searles and many people who do choose to work with psychosis say that they learn the most about themselves when they work with psychosis, more than other types of pathology.
Right, right.
I know
Dan-
I found that.
I'm sorry.
Go ahead, Mike.
Danielle's comment reminds me of a subtle but prevailing distinction that therapists often make to protect themselves. Even identifying, oh yeah, I know what he's talking about, is often couched in terms of what I'm afraid of becoming. And what I found from all those years of supervision is to break down that barrier of becoming and often point out to the therapist that in our relationship, in the supervised relationship, they're not becoming, they're being.
Hmm.
One thing that's very helpful in that regard is when you experience it yourself, acknowledging it. You know what? I find myself wanting to end this supervision. I feel very uneasy about myself. I don't like what's going on. I
Right.
understand why it's hard for you to sit in the room with your patient. There is an empathic connection that propels security because, as Danielle says, isolation is the key factor until a sense of enough safety to peek out from under the barriers emerges. And we'll be
Right.
talking about that throughout.
Right. I mean, part of reading the chapter on how psychosis masks loneliness was what was so fascinating to me, because I related to it and had me thinking of so many things I had never considered working with people that I never thought had psychosis or who don't have psychotic symptoms. So, especially in the wake of the pandemic and the isolation that has happened since, and just lack of more aloneness, lack of human connection. It's something that I think, well, my question is, how do you think that is affecting people with psychosis now, that isolation, and how do we as therapists connect to them through that? Can we connect in that way? Yeah.
Okay. Well, look, loneliness, before I said fear was like the main consistent attribute that we see in psychosis, but loneliness is a close second. Loneliness is critical in psychosis, and many people who are diagnosed with psychosis claim to feel lonely up to 6 times more than the general population. I mean, it's really a lot more.
Very scientific.
What?
Very scientific. Very scientific.
This
Good.
is research. This is based
More.
on research that's been done and
Yeah,
asking
yeah,
people. Today, we know that loneliness, we talk about a loneliness epidemic. And there are loneliness ambassadors, or, in different countries like Japan and the UK, just to address that issue. But loneliness in psychosis is much more, is experienced as more severe, because not only does the psychosis isolate the person, when we hospitalize someone and take them away from their environment and their people and their work, that isolates them. When we medicate them, they become lonely and alienated from themselves, because so much of the time the medication itself turns them into strangers to themselves. And so that is a very isolating and frightening experience. Sullivan, who worked a lot with psychosis, claimed that loneliness is the most painful human experience, human emotion. And one can argue that, but it certainly is a universal experience.
Right.
Psychosis, one of the things that we address in the book is how a lot of psychotic symptoms actually are attempts to deal with loneliness. Many people from Freud on, Freud felt that psychosis was not treatable psychoanalytically because he thought that the person with psychosis could not develop a transference, and transference in his mind was so essential to the treatment of psychosis. But he was wrong. And there were certain periods where he thought, well, in the future, people will figure it out, just like female psychology. In the future, another theorist will figure it out. But psychotic symptoms, whether it's hallucinations, many people create hallucinations that keep them company, so they feel less lonely. Or delusions. We think of delusions. People are always interested in them. There is a connection, albeit a frightening connection, a dangerous connection, but it keeps the person connected to others. People are interested in them. The worst thing is indifference. I don't care if you exist or you don't exist. But even a delusion is preferable to that, because the delusional person is always feeling a connection to others. They're interested in them. They're after them. They're following them. And the person with the delusion is constantly in some kind of imaginary or projected connection with the other, the projected other. So once one understands these ways that psychotic symptoms are actually attempts at connection, at creating connections, one will intervene differently. One will make their interventions differently, because one can address the desire for connection, not just the desire for withdrawal, which many people focus on.
My neurotic patients come to me complaining about being isolated. I want to be less lonely. The first step in working with psychotic patients, particularly chronic, we haven't made that distinction much thus far, but I want to draw on it here. Particularly chronic schizophrenic patients will present with isolation not as something to be dealt with and removed, but as something that is vital, urgent, emergency, preparation for dealing out of the world, so that you don't begin with this amiability about, let's see if we can help your isolation. It's just the reverse. And that's often the difficult part about starting a treatment. You think you're very well-intentioned, and hey, how are you, and all of that, and we're going to make a bond together. My experience with chronic schizophrenic patients is that the first step is always the opposite.
Right.
Just the opposite. I don't know. I'm not even sure why we're meeting here. I don't know that you want anything from me. That's going to be difficult for me to live with, but I'm going to try. And every time you feel I'm intruding on you, let me know. Now, I'm putting this in very secondary process ways, but most of this communication will be done through symptoms and behavior. What do I mean by behavior? An example would be sitting quietly for weeks. Nothing is going on, apparently. At least nothing that can immediately be used as external justification. Somebody says to you, well, how is your patient doing? And you say, geez, I sat there for 3 weeks and I didn't say a word. Well, that's not an apology. That's a description of a treatment philosophy enacted. So the first step is just that. I can tolerate your wish not to tolerate me. I get it.
Yeah.
I need this from you. I'm just going to be here and let's see what happens. And
Right.
if I intrude on you in any way, it is a terribly important thing. I hope in some way you can signal what it is. Right now, I notice that there's no room for that concept because you're completely shut off from me. But I notice that you listen every once in a while, even though most of the time your eyes are closed, but your ears are open and you haven't walked out of the room. And if you were to walk out of the room, I'll be back tomorrow.
So what appears from the externally, what appears to be doing nothing in a way is actually the hardest
Oh, yeah.
challenge, the biggest challenge about being a therapist, and not only with working with psychosis. And so part of what I was wondering while reading the book was that how do you deal with all the energy that actually like doing less, taking less action seems to require a lot of energy and creativity and flexibility to do that, to not be more directive in that way. So I was wondering what that is like what type of energy it takes to, while you're sitting with this person, to really start to understand that way of being, different way of being, a very different way of being.
Well, one of the things you need to do, first and foremost, is not have the patient prove your therapeutic worth. You have to feel comfortable within yourself that there may be no apparent progress, none, and that none of that shakes your idea that you're doing anything but recognizing the impossibility of the task and how to then approach that. In other words, to be respectful of my effort, first of all. I realize this is what I'm doing. I may not get anywhere. This is hard work.
Yeah.
But
I see that's
I'm
less.
learning all the time, and I can present that learning to my students as part of what I'm doing through. And I also recognize that it will help me sit more easily with the patient. So it doesn't take so much energy as an appreciation that I'm okay as a therapist. This patient will not prove or disprove my value to the therapeutic community or to myself.
I see it a little bit differently. I agree with what Mike is saying, but when I work with patients like this, and there's a long case example of mine in the book, of someone who I sat with silently for months on end. I didn't see it so much as requiring a lot of energy. I saw it more as just being with another in the place that they can tolerate. And so in some ways, I think it's harder for early career clinicians to do that because they have more to prove and they feel that they want to do and see results and be, look what I can say that gets, that's intelligent and insightful and all that. And you have to kind of disabuse them of that with these kinds of patients that will not take well to that kind of intervention, and they'll feel it invasive and intrusive, and it will break the treatment. So with these patients, if one can just be, and maybe for a lot of people that is difficult, but just be there, and recognize this is, I see what you need from me and what you don't need from me at the same time, so that I'm going to be here and take my cues from you. And you see little, you begin after a while seeing little changes. The fact that they even show up, the fact that they show up is already an indication that they're connecting in their way. They might not do much more than just show up, but that's enough. They might show up for 5 minutes, and that's enough, and that's fine. The next time, it may be a little bit more than 5 minutes. Frieda von Reichmann famously saw a case at Chestnut Lodge who refused to meet with her, would stay in his room, and she just brought her chair to outside the room at a certain time every day. And the patient ignored her, and every day for months, she was just sitting there for a few minutes, 5 minutes, 10 minutes, until one day he just looked up and he said, "What are you doing here?" And she said, "I'm waiting for you." And they began conversing. And that was an opening. So it was like, I'm here until you're ready. When you're ready, you'll indicate, and we can move to the next stage.
So
Yeah,
when you,
I want to add a clinical vignette brief to that I think illustrates Danielle's point. I sat with the patient for quite a while. Then the patient took his chair and turned it around.
Mm.
So what I said to the patient is, okay, I may not be understanding this correctly. And if I'm wrong, I'm sure you'll figure out a way to tell me that, as you did with the chair turned around. But I'm going to make a guess. And with that, that's all I said. With that, I picked up the chair and turned my back to him.
that sounds like like the use of play, like that.
Yes. Oh, there
Yeah,
has to be.
Yeah.
Oh, play is essential in this work. My
Yeah.
goodness.
Yeah.
I don't know how you do it without a sense of play.
Yeah.
Right.
But the play is based on empathy.
Yeah.
The clue for the play, the play is the creative, what am I going to do with it stuff. But the play begins with, what's going on here? And you may be wrong about what's going on, and it's trial and error. So I might conceivably, I didn't need to in this case, turn the chair back around.
Right. Right.
Yeah, exactly. So speaking of chairs, the example that I give in the book of this patient who didn't speak for a long time, at one point things started moving a little bit, and he started expressing a little desire for connection. And one day he came in, he said, "Can I move my chair closer to you?" And I said, "Yeah." This was a big, thing. And he moved his chair closer to me. And as soon as he did that, he began associating to cannibalism. He was clearly very frightened by this instant intimacy or closeness that he thought he wanted, but was frightening to him. So I instantly said, "I forgot to tell you that you can also move your chair back." And he, with enormous relief, moved his chair back, and we continued. But the point there is, like Mike was saying, play means there are alternatives. You're not stuck. Psychosis sometimes, and any mental illness, is being stuck. And so when I offered that there was an alternative, he could move it back. Now, he wasn't stuck there. It was like, okay. And that becomes a paradigm for other behaviors, that things can have other choices beside this one.
Yeah.
Right.
The islands of clarity. That is something I'm curious about knowing more about, that you spoke about. Can you talk a little bit about the Islands of Clarity?
Edward Podval was a Buddhist psychoanalyst, and he worked at Chestnut Lodge. He was analyzed by Searles, and then later he worked at Austin Riggs. And he brought a kind of Buddhist sensibility into the psychoanalytic work. Eventually, he relinquished everything, went to France and became a Buddhist monk for 20 years. But he came up with this idea of islands of clarity, islands of sanity, that we know that no one is 100% psychotic all the time. And so he said, we have to take a history of sanity, not just a history of pathology. So many times people are taught, to take a history of symptoms. Okay, you're hearing voices. When did you start hearing voices? How often do you hear voices? What medication are you on? How do you have any side effects of the medication? It's all centered on pathology and nothing on clarity, on sanity. Where's the healthy part? And so he came up with these 5 islands of clarity, and I'll just say them briefly. But obviously, there can be more than what he came up with. One of them was repulsion. These are things you might not think about. When somebody expresses disgust or a repulsion towards their own symptoms. I hate being this way. I don't like that I'm this way. That already says there's an observing self that says, I don't like this. I want to be different. It's kind of like AAs. I'm sick and tired of being sick and tired. It's like, okay, you've gotten to a point, you're ready to change, or you might want to change. The second one was going beyond the self. This is very Buddhistic, right? The ability, the desire to transcend the self. Again, this self is causing me pain. It's causing me problems. I want to transcend this self. The third was discipline. We almost never ever, I know in all of my training, no one ever mentioned the word discipline. And the importance of discipline for a healthy life, to be able to adhere to a schedule. First of all, discipline is important when we're assessing whether somebody can come to therapy. Can they keep to a schedule and come to the appointments as scheduled? Does somebody, have discipline in how they write, in gardening, in cooking, in anything that they do, exercise? That's already a sign of clarity, that they can, manage that. The fourth island was compassion. When somebody can show compassion for others it could be a pet, it could be an animal, or even, of course, it could be for themselves, because there's often a lot of self-hatred and violence against the self in psychosis. And the fifth was courage. We talked about fear being a common premise in common affect in psychosis, but courage, the courage to do things, to take risks, to play, right? To take risks and to confront oneself. I'll give a small example of a patient of mine who came to me 5 times a week and revealed to me years into the treatment that every time she came to my building, there were hundreds of rats at the entrance. And she had to arrive an hour early in order to, and would wait until these rats cleared off and made a path for her to come through and come to my office. Now, somebody who has a medical approach to psychosis would immediately say, she's hallucinating, these rats, she needs medication fast. But what I saw was this woman was confronting these hundreds of rats in her mind, which obviously represented some kind of demons or dark parts of the self that she felt she was going to have to confront by coming to treatment. And she she had the courage every day to go to confront these rats and to get through them and come to my office. She was never late. Somehow the rats parted the seas, and she came. So to be able to see what seemed like very pathological psychotic symptoms in their more positive light, that they can represent other things like repulsion, like wanting to go beyond, like discipline, like compassion, and like courage. That's what Podval meant by the signs of.
I want to say something about the islands of clarity, which was a phrase, unfortunately. Danielle wrote the chapter and I must have glanced at it, but it didn't hit me so clearly. I would say all this is fine, except for the timing. Patients have been told repeatedly by family and friends, but you were such a star, you did so much, your parents are so, what's the matter with you? That kind of thing.
Yeah.
And I would be very loath to bring up anything positive with the patient at the moment that we begin, because, and that's why I say timing, I think, is important.
Yeah.
Because at the beginning, what you're trying to do is to communicate that you can accept him or her as the patient feels him or herself to be. Now, if it's grandiosity, that will be dealt with later. But whatever it is, I would not want to begin in any way with any suggestion of your strengths, but rather to deal with your terror, and not even to ask about strengths at that point, because asking about strengths is a reminder of what everyone is doing with that page. Buck up, remember what you have, your parents love you, and to focus on that early. And I'm not saying this guy believes in doing that, but I'm emphasizing timing here because I think it's crucial. To do that would be to move away from where the patient is. And the initial contact must be a presentation of self in respect for what the patient experiences him or herself to be at that moment.
I don't disagree with that.
Firstly, I just want to say one more thing about supervision in this. I have found that residents, physicians, analysts, people who have come to me for supervision will often, out of a fear of what they're dealing with, remind themselves and then remind me how much talent the patient has. And when it comes at a time when they're veering close to feel, the therapist, when the therapist is coming close to feeling overwhelmed, I want that to be known, because that sense of overwhelmedness, not blocked by the patient's record of accomplishment, that sense of overwhelmedness is the pathway to identifying with the patient.
Hmm.
And I
Yeah.
just want to say one thing about this meeting altogether. I know we're moving into another section. I personally have found this very invigorating. I've learned a lot. It stimulated me
Yeah.
very much.
And we're all here from the privacy of our own homes, or we're remote, but we're
Yeah.
together. And when you talked about patients' strengths or the islands of clarity, where discipline and courage is required and routine just to get to the office. How do you
Yeah.
think technology and the way that we're meeting more remotely is affecting or will affect the treatment of psychosis?
Yeah.
I'm studying technology a lot these days, and there are there are certain technologies. First of all, I've seen patients who didn't want to come in to the office. They were too frightened. They were, being pursued by demons, or they felt they were bringing demons into the office that would infect my my patients. One of the things I noticed with COVID is that some of my patients who were experiencing psychosis or who identified as psychotic told me, well, now the world knows what life is like for us. Because, suddenly, people were isolated and feeling lonely. People were paranoid. Where's this COVID coming from? Who's going to infect me? The germs. There are a lot of very paranoid symptoms among, so-called normal people. So there was almost like a smugness, like now the world knows, welcome to my world. But as far as technology, there's what's called avatar therapy now. A scientist who recently died in the UK, developed a method of creating avatars of patients' hallucinations, visual hallucinations. And so he would create an avatar that the patient then interacted with. So it externalized their hallucination based on the description, and they were able to interact with this avatar. And they found that, it increased the feeling of empowerment, decreased some of the negative associations to the hallucinations. So that is in development at the moment. I'm thinking what else? AI is being used to predict risk of developing psychosis, to detect early signs. We might not, fully agree with this. They might have these false positives in doing that. One of the positive ways that technology is functioning for psychosis is creating online communities. We're talking about the isolation and the loneliness in psychosis, and there are many online communities now for people where they share their experiences, they help each other. Hearing Voices Network is a peer-led group of people who hear voices, who don't necessarily want to be their medication to take away their voices, but they help each other learn how to live with the voices. So it's a very positive group. So they share, they give mutual support, and of course it fights loneliness. So there are some technological advances in this realm, in this area.
Yeah, I mean, there's so much in this book, so many questions I had about the treatment and when to end, and but I just wanted to ask about if there's anything you want to just share about the book before we move on to, it's about time to move on to open it up for questions. And I want to just, before we do that, see if there's anything you want to share about the book regarding either the ending of treatment or anything else that's important.
I think we're just hoping that this book, we've mentioned early career clinicians and supervisees. We want to emphasize that this book is not just for beginning therapists, although I think it will be very helpful for beginning therapists, but it's also for experienced therapists who don't have that much training or knowledge in dealing, and who want to learn more about working with psychosis. The book is filled with case material. So it has a lot of vignettes to illustrate everything that Mike and I are saying, and it has several long case descriptions from beginning to the end of the cases. So you can, follow these cases from beginning to end. So I think that's what I wanted to say.
Well,
Yeah.
I would like to ask the audience, apropos of what Danielle is saying, whether after reading this book, they feel any more confident, competent, interested in, curious about working with psychotic patients, and what is getting in the way of that. And in other words, what is getting in the way of that would be a wrap on the book, because it's a question then of an omission in the book.
Yeah, yeah.
Okay.
So be in touch with us, those of you who read the book.
And the last thing I would say by way of illustration is if anybody in the audience has a vignette or an impasse with their patient, I think we could discuss how to deal with that. That would be both illustrative and immediate.